Hello, everyone, and very much welcome. My name is Elisabet Stener-Victorin, and I'm a professor in reproductive physiology. And today I will talk about, I took the title Hormones During Pregnancy. How does it affect the growing baby? I have the outline of my talk today is that I will talk about the topic we are researching in. It is polycystic ovary syndrome and what it is. I will talk about pathophysiology of a syndrome. And then we come into hormones during pregnancy because polycystic ovary syndrome is related to hormonal disturbances. And how does it affect the growing fetus? And lastly, but not least, I will talk about our ongoing research, what we are actually doing right now in the lab. So to start off, what is polycystic ovary syndrome? Yeah, it is the absolutely most common endocrine and metabolic disorder, and it can affect up to 17% of all women. You get the diagnosis by fulfilling 2 out of these 3 criteria. It is either hyperandrogenism, and hyperandrogenism means that you have high levels of circulating male hormones, androgens. And the clinical symptoms of that is that you get disturbing hair growth, you can get male pattern baldness, that you have thinner hair growth, and you can also have problem with acne. So that is typical signs, clinical signs of hyperandrogenism. Oligoanovulation means that you have irregular cycles, menstrual cycles. And if you have longer cycles than 35 days, it says that you have irregular menstrual cycles, and it's usually linked to irregular ovulations as well. And polycystic ovarian morphology. And what it means is that it's not cyst person have with polycystic ovary syndrome. They have many follicles that are not developing fully. So it is more follicular morphology we are talking about. And these women are usually have problem with subfertility. They are not infertile because they can be pregnant, but they have also pregnancy complications, which I will come back to. It's also linked to metabolic disorders like type 2 diabetes and cardiovascular disease, but also psychiatric disorders such as anxiety and depression disorder. And we know that when a woman with PCOS become obese, it's aggravate all their symptoms. And it's also increased the prevalence to over 25% in obese women. So first, I will talk a bit about what we know about the symptoms and how we manage this. Polycystic ovary syndrome accounts for up to 80% of women with anovulatory infertility, so they have irregular cycles. And the treatment of this, if a woman tries to conceive but they do not conceive after 1 year, they need to be treated in some way. The first line of treatment is always for these women lifestyle management. And lifestyle management is to have a healthy diet, do regular exercise, and of course not doing too much, being too much stress. But if it's not helping, some kind of ovulation induction can be done. And usually the first line ovulation induction is clomiphene citrate, or letrozole, or metformin. Metformin is an anti-diabetic drug, and is more related to if you are obese and have insulin resistance. But letrozole is the drug of choice today because it has been shown to be superior to clomiphene citrate, but it's not used in all countries in the world. If that doesn't work, if they have done several cycles and they do not become pregnant, they go on with gonadotropin and laparoscopic surgery treatment. And if that doesn't work, they go to IVF. Sometimes they skip the gonadotropin step and go to IVF directly. There are also other non-pharmacological treatments like just doing exercise or acupuncture or herbal medicine that is tried by many people. But they have not been shown to be superior to the first line clomiphene citrate and letrozole in ovulation induction. But they are associated with less side effects. So if we look at the more the hyperandrogenemia, how do we cope with that? Yeah, hyperandrogenemia, they wanted to call female pattern hair loss, not male pattern baldness, as I said before. They have changed the name very recently. As you see, it's February 20th February this year. They pushed that it should be called female pattern hair loss. And the first line of treatment is minoxidil. It's actually an vasodilatator that is used for treatment of severe female pattern hair loss, or other 5-alpha reductase inhibitors, which inhibits the conversion of testosterone to the more potent DHT, or anti-androgen treatments when this hair loss is really severe. Also, women with PCOS is related to more severe metabolic disturbances, impaired glucose intolerance and type 2 diabetes, independent of ethnicity. So this is the prevalence of a syndrome is more or less the same in different parts of the world. But the presence of a syndrome may vary a bit. For example, in China or more in the East Asia, the male pattern hair growth or female pattern hair loss is not that pronounced. There is more the other symptoms. It's also linked to cardiovascular disease. And women with PCOS have higher cardiovascular disease event rate, including hypertension and also dysfunctional lipids. And again, the treatment of these, you all know that it is lifestyle management. They have to try to reduce weight and of course doing exercise. Something that my group also look into quite extensively is their problems with anxiety and depression. And it has been demonstrated that women that have PCOS diagnosis is linked to increased risk of moderate but also severe depressive and anxiety symptoms. And the odds of having anxiety symptoms is at as high as almost 6. And having depression is slightly lower but still very high. It's up to 4. So the research community say that polycystic ovary syndrome and mental health, it's really a call to action. And it's known that, or many women with PCOS who actually seek help because of they feel bad, they do not get the attention and treatment that they might have. So this is something that is really important. I have been part in developing and extending an international evidence-based guideline for assessment and management of polycystic ovary syndrome, which was launched 2018. And that involved all countries in the world, more or less. And by digging into all the evidence for each part of a syndrome, we have taken out what we know, the level of evidence for each part, how they should be diagnosed, assessed, and also treated. And I have to say, in several parts, the evidence is very low, unfortunately. But at least this has put the research community together. Now we have a very big task, and that is actually to reach out to the persons who meet these patients. And there are a number of patients' organizations. Unfortunately, in Sweden, it has been very silent. But now, after we have launched these international guidelines, it starts to wake up again. However, the other Nordic countries have much more active patients' organizations, and they try to take help from them. And this international guideline group have also developed an app that you can download at the App Store. And this is very much for patients, so they can get guidance and where to seek and what to do and so on. And it's really nice. They're also developing general practitioner guidelines, because if you read this book, it's several hundred pages. They have diluted this or taken this into a concept, that leaflets, that if a patient come with these symptoms, you should do this. And if they come with these symptoms, you should do that, and so on. So it's really handy and very good. So we are on the way, and there are other countries like in US and in Australia, they are very strong related to the patients' organizations, and they have PCOS health days and join the fight against polycystic ovary syndrome, HELP, and PCOS. And the PCOS month of the year is August, so you know that. So despite the high prevalence of PCOS, the underlying cause is largely unknown. So coming to what is actually happening in the body of these women, we know that they have a high pulsatility and secretion of luteinizing hormone from the pituitary, LH. And they have normal or rather lower follicle stimulating hormone. LH is stimulating the ovaries, and it's stimulating and contribute to the secretion of androgens. So it's stimulating the theca cells to produce androgens. And here we also know that the adrenal gland contribute to the hyperandrogenemia. It also inhibits and impair the follicle development, contributing to the anovulation or irregular cycles. As I mentioned, women with PCOS also are more likely to have metabolic disturbances, including type 2 diabetes, as I said, but many have pre-diabetes with hyperinsulinemia and insulin resistance. And hyperinsulinemia, so they have high secretion of insulin, it decreases the production of sex hormone binding globulin from the liver, further contributing so you have more free available androgens circulating. But it also stimulates the theca cells in the ovary to produce androgens. So you have both the insulin and you have the LH that actually contribute to the hyperandrogenemia. And then, of course, obesity. It's not cause of a diagnosis, but it makes everything worse. Many of the symptoms linked to polycystic ovary syndrome is also linked to a high activity in the sympathetic nervous system. And we know that, for example, hypertension is very closely linked to high activity in the sympathetic nervous system, but also insulin resistance and type 2 diabetes. Obesity per se is linked to high activity in sympathetic nervous system, and also the hyperandrogenemia. We also know that there are genetic factors involved in the syndrome. Altogether, this causes a vicious circle, and still we do not know where it starts. Is this a central nervous system history? Is it an ovarian history? Or is it more a metabolic history? We do not know. There have come out a number of genome-wide meta-analysis demonstrating that there are specific genes linked to the syndrome. And last year, a number of researchers, as you can see, we got together all our results into one unique database. And then we scrutinized all the data we had and found 3 new susceptibility SNPs and genes that might contribute. So there are around 20 known genes that contribute to the syndrome. However, the genetic factors only explain a small part of the heritability in the syndrome. So there must be something else contributing to it. So this cartoon comes from one of my PhD students' thesis. So we have the genetic variation. We know that. And that might cause polycystic ovary syndrome. But we also have environmental factors that we know affect and cause many of the symptoms that women with PCOS have. And in particular, what we are focusing very much on is the intrauterine conditions, but also the diet, which is of course linked to obesity. And we believe that this may cause epigenetic changes and contribute to the insulin resistance and the hyperandrogenemia. Also affects the different tissues like adipose tissue, skeletal muscle, but also pancreas, liver, and of course the ovaries. So it might affect all the somatic tissues in different ways. So the question, genetic and epigenetic factors, is there. We have taken from our clinical studies a cohort study that we had women with and without polycystic ovary syndrome. That we have done a lot of measure. We have measured their sympathetic nerve activity, their insulin sensitivity. And we see that they are insulin resistant, independent of obesity. And we have measured all their sex hormones and so on. What we also did were that we collected adipose tissue samples. And we ran a genome-wide DNA methylation array and a global transcription and RNA array as well. And we have done exactly the same in skeletal muscle from women with PCOS. And we see here that women with PCOS have multiple epigenetic and transcriptional changes in both subcutaneous and skeletal muscle that may be relevant for the development of a disease. However, this is just a snapshot, and we see that they had this, but we cannot say that this is the cause. So the big question is, where and when does it start? And our group, we are thinking that what happens in utero, in the pregnant mother, may affect the growing fetus. And this is something that has been highlighted more and more the latest years. For example, this Time magazine showed this picture, and it was 2010, I think it was, how the first 9 months shape the rest of your life. And this is something that is very important. We know that hormones during the pregnancy vary, and they are usually increasing. It's both the placenta that contribute to this, it's the mother, of course, and also the growing baby, or the fetus, contribute to androgens. And we know that progesterone and estrogen increasing during pregnancy, and not much is mentioned of testosterone. But we have demonstrated that women with PCOS also have elevated circulating testosterone compared to non-PCOS women during pregnancy. So a woman with PCOS has also been demonstrated to have an increased risk of adverse pregnancy and birth outcomes. They are more likely to be obese during pregnancy, to develop gestational diabetes, which of course affect the growing fetus, have preeclampsia, preterm birth, and give birth to either small for gestational age or large for gestational age babies. So they can both give a growth restriction or an overgrowth of a baby. So the PCOS mother is a possible source of maternal androgen excess. So the PCOS mother we believe that it can affect the placenta and the placenta sterogenesis, and thereby also the growing fetus. But of course also the growing fetus might contribute the adrenal gland and the fetal liver and so on, also affect the placenta and the function. So the placenta is crucial, of course, the growing fetus, and maybe the most important, the offspring, and what happens in their adult life. So we took placenta from women with and without polycystic ovary syndrome, and in the late pregnancy we also measured circulating sex steroids. And here in this study we found that they have high levels of circulating testosterone, but also other androgens, whereas they had relatively lower circulating estradiol level or estrogen. And a number of genes related to nutrition and glucose transport in the placenta, and also to the steroidogenesis and steroid function in the placenta was dysfunctional in these women compared to non-PCOS women. So the intrauterine environment, it has the potential to affect the offspring, the growing baby and the offspring. So what clinical evidence of a maternal androgen exposure is out there in the clinic? And it was actually the first time last year, 2 research groups measured anogenital distance in women with polycystic ovary syndrome compared with the control. So it was not the offspring, it was just women. And they found that they have an increased anogenital distance, which is a marker of androgen exposure in utero. So 2 studies published in Human Reproduction 2017 shown that they have a larger anogenital distance. And last year, another group from US demonstrated that the anogenital distance in the newborn daughters of women with polycystic ovary syndrome has an enlarged anogenital distance. So this was actually the first time they showed that it was the daughter of a PCOS mother that presented with this. It's not that the high androgen levels later in life caused this. A strong marker for intrauterine androgen exposure. So, does maternal androgen exposure affect the growing fetus and the offspring? Yeah, we have demonstrated that they have increased testosterone and dysfunctional placenta nutrient transport, but also steroidogenesis. And this cartoon demonstrates, and what is written here, I wrote here, the eggs that may someday become the grandchild are developed inside the daughter while she's still in the womb within the mother. The eggs are nourished by the diet and environment of the mother. So of course, if a mother with PCOS are obese and also have high levels of circulating androgens, it may affect not just the growing baby, but also the growing baby's becoming next generation, the germ cells, we also call it. And a PCOS mother, a woman, is at an adverse risk of pregnancy and birth outcomes. So it may affect the offspring health. And what we are also looking into, that this inheritance may also continue across generation in unexposed females and males. This has been studied in the obesity field quite a lot. So they have fed mice with high-fat diets, and they have also studied obese mothers becoming mothers. And they have shown that the germline, or the growing oocytes, have a dysfunctional mitochondria in the germ cells. And they think that this is an epigenetic changes. So the first generation's offspring have mitochondrial dysfunction in their oocytes, which is transferred into the second generation. So the second generation germ cells are exposed in utero, but it's also transferred into the third generation that is completely unexposed. And that is what is meant with a transgenerational inheritance. Whether this is the case from a mother with polycystic ovary syndrome or exposed to high levels of androgens is not really known. We use different animal models to try to investigate this, because as you can understand, to go from the PCOS mother to her daughter and into next generations, I would not be here. I would be retired a long time, but my group can take over that. But we use, I would say, rhesus monkeys are the best model to be used, but we use the rodents and preferably mice, and we expose them for maternal androgens and obesity, with or without obesity, but we're also using prepubertal androgen exposure, so they have a PCOS condition, and then we use them. In parallel, we always, I would say, run clinical studies that we study both women with and without polycystic ovary syndrome, and we also evaluate the efficacy of different treatments. Right now we have an ongoing study that we evaluate the effect of metformin or acupuncture compared with lifestyle for improving insulin sensitivity. So a bit what my group have done in this field now. Romina Fornes, she defended her thesis last year. She have demonstrated that when we use the maternal androgenized model together with diet-induced obesity, we see that it alters placenta and fetal liver function, and also the expression of essential proteins and enzymes. And we can see that androgens is a very strong marker, and of course also the diet-induced obesity. So what happens with the offspring? Another postdoc, Min Hu, did a really nice work that we used rats that we exposed prenatally to testosterone. And then we followed the first generation of offspring and measured both their metabolic and their reproductive and also their behavioral phenotype. And we found that they had their reproductive phenotype, they are metabolically disturbed. But the new finding here was that we also saw that they have an anxiety-like behavior phenotype. And this was very novel in this field. And we could actually track this down. So we demonstrated that it is the limbic system and amygdala in the brain that contribute to this, because we could tag it down to genes that were dysfunctional in this brain nuclei. This work was followed up by Maria Manti, that is a PhD student in the group right now, that we walked over to the mice, and here we combined with also high-fat diet, so they're diet-induced obesity. And here we can see that the maternal androgen excess and obesity induced sexual dimorphic anxiety-like behavior in the offspring. And it's preferentially the female offspring that develop an PCOS-like behavioral phenotype. What we also currently do is that we measure or investigate whether these mice, the first generation mice, also have cardiovascular dysfunction, which they have in relatively young age, if we can say so, in the mice. They still do not have hypertension, but when we investigate the heart function, we can see that they have a dysfunction in the heart, they have more fibrosis, which is the pre-stage of a heart failure, actually. And the question is then, can this be inherited or transferred into subsequent generations? So Sanjeev, that is postdoc in my group right now, have done an extremely large project that we fed the mothers with high-fat diet and gave them androgens during pregnancy. So this is what we call first F0. And we follow the first generation, both female and male offspring. Second generation, by mating these females with males, we get the second generation, and then we follow them into the third generation. That is a completely unexposed generation. So that we have control diet and vehicle, so they are the control. Control diet and androgen exposure, dihydrotestosterone, and diet-induced obesity and vehicle, and diet-induced obesity and DHT. And then we have followed these mice for checking their reproductive function, body composition, we measure their metabolism and behavior. And we are doing a lot of molecular analysis here also. We have run single-cell RNA sequencing in the oocytes. We're looking into the sperm function in the males, and a lot of other molecular analysis. What we found in this study is that they develop a reproductive phenotype that it's partially transferred into the third generation. The strongest marker, as I mentioned before, the anogenital distance, is transferred into the third generation. They also have metabolic dysfunction. They have more fat accumulation in the more adipose tissue. They weigh more. They have disturbed energy metabolism into the third generation. But we also found a relatively severe phenotype in those first generation females that come from a mother that was obese and exposed for androgens. They have miscarried early during their pregnancy. So Hao Yang Lu, who is a PhD student, very new in the group, we repeated the whole experiment and tried to find out when does this happen. So we do this, take the embryos in 12.5 and very late during pregnancy, and measure if they are growth restricted, or and also take images of embryos and so on. So I will not go into detail in the results because these are ongoing studies, just to give a glimpse of what we actually are doing right now. These studies that we have done so far study really what happens in utero. And we show that this increases susceptibility to transgenerational transmission of a PCOS-like phenotype into the third generation. That we demonstrate here. But what we do not really discriminate between is whether it is the intrauterine environment that is causing this, or if it is the germ cells here that actually cause this transmission. So the ultimate question is, does androgen exposure prior to an in vitro fertilization lead to an inheritance via the germ cells? So we will expose the mice for androgens, and then we will do an in vitro fertilization and place the embryo into a surrogate mother that is completely unexposed. So then we will tease out this. So that is what we are doing right now. And here we will also see if we can prevent this development by putting the mice into a running wheel. We all know that exercise is the first line of treatment for these mice. Or we will give an anti-androgen treatment, flutamide, in the becoming mother or donor, we would call them here. And so they will donate their oocytes, and then we have healthy males and put them into the foster mother. So we get the first generation. And then we will do the second generation and the third generation. And we will do exactly the same phenotypic testing. So we can tease out whether this is a direct intrauterine environment that causes it, or it's the germ cells. As I mentioned, we also have clinical studies, and this is Josephine Kataoka, who is a gynecologist that is working with obese, and I call severely obese women with polycystic ovary syndrome. And what we actually have done here is that we have screened 300 women that are coming to an obesity clinic, whether they have a diagnosis or not, and if they are more likely to have metabolic syndrome, and how they respond to a 1-year weight reduction program at the obesity unit. And Anna Benrick is another very close collaborator who did her postdoc in my group, and we are continue to work with the clinical data, the epigenetic and transcriptional changes in fat and muscle in women with PCOS, and also if muscle contraction can restore insulin resistance and these epigenetic and transcriptional alterations. And last but not least, Eva Lindgren is a research engineer in my group, and she's involved in more or less all the projects, and especially also helping out with a clinical project that we do cell culture of fat that is collected freshly, and also other molecular analysis. And finally, not least, the whole group together and all the funding agencies. Without them, we could do nothing. And I have a lot of collaborators, but this is just to mention a few that we are actively collaborating with now. Shaolin Deng and Anna Krok and Nicholas here, and also Angelica Lindén Hirschberg here at Karolinska, and Charlotte Ling and Alexander at Lund University, and Claes Olsson is doing all our sex steroid measurement in the serum and also tissue in Gothenburg, and Kurt Höjlund is from Odense in Denmark. Thank you very much.